So the majority of ruptured aneurysms are fortunately neither large nor giant, they are small. And it's a terrible misconception to think that small aneurysms are harmless. The opposite is true. So the majority of aneurysms we see in a ruptured condition are between 3 and 6 millimeters. And on the other hand, large and giant aneurysms frequently are a technical challenge for both microsurgery or endovascular treatment. And there is certainly no universal standard solution for these aneurysms. And we go for a totally individualized treatment concept in the far majority of cases. So we have statistics from 2007 to 2020 with 983 ruptured aneurysms we treated, and 9.7% were large and only 0.8% were giant. So ruptured giant aneurysms are really rare. You may argue that the majority of these patients may not come to medical attention because they simply die from the rupture before they arrive on the angio table. So these are 3 examples. This is a ruptured internal carotid artery aneurysm, the ACOM aneurysm, fusiform basilar aneurysm, the so-called megadolico-ectatic basilar artery. And all these patients died. As you see here, there's already massive hematoma and midline herniation. This is instantaneous increase of intracranial pressure and the interruption of cerebral perfusion, and these aneurysms usually destroy the brainstem of the patients. For those patients, there is no endovascular treatment. The only thing you can do is to fill out the death certificate. Clipping of these aneurysms is frequently propagated, however, together with the removal of the hematoma. However, clipping of these aneurysms is everything but easy. As you see here, this was done by a really experienced neurosurgeon. And you see here most of the middle cerebral artery is missing after the clipping. So he clipped the aneurysm, but in the very same moment he clipped most of the middle cerebral artery. Even if we do something for these patients, in that particular case, this was a PCOM aneurysm. We coiled it partially, knowing that this partial coiling in the far majority of cases is enough to prevent re-rupture. So this looks not very elegant, but as a matter of fact, if you wait for half an hour, the aneurysm is going to be thrombosed and will not re-rupture most likely. However, the patient eventually died from vasospasm in both anterior cerebral arteries. So he had secondary vasospasm and died from the vasospasm-induced increase of the intracranial pressure. So it makes little sense to show maximum effort in the acute phase, because whatever you do, the majority of these patients are going to die anyways. This was a young lady. She was presenting at 10 in the evening in a hospital with severe headache. They gave her migraines, didn't do anything, gave her migraines medication and sent her home. 4 hours later, she lost consciousness, and she was living in an odd place. So it took 3 hours to bring her from the room to the ambulance. So they had to do any kind of technical things to bring her out of the home. And when she arrived, she was deeply comatose. The pupils were still constricted. And you see here, there's massive hemorrhage in front of the brainstem. And it was a very odd dissecting aneurysm. As you see here, the basilar artery is dissecting all the way up, and the posterior cerebral arteries and the superior cerebellar arteries are coming from the top of this kind of a balloon. So nicely shown here. These are the posterior cerebral arteries, the superior cerebellar arteries. So what to do here? Fortunately, she had a competent PCOM, so the posterior communicating artery had the connection to the posterior cerebral artery. So the only technical solution we had was putting a Piconis, a stent, underneath the bifurcation of the basilar arteries. We coiled everything below, everything underneath the Piconis. So this, you may call it the inverted Piconis technique. So usually you put a Piconis and you would coil this. In that case, you would occlude everything. So we did the opposite. What the Piconis is meant for. Piconis crowns underneath the bifurcation, every coiled here, and we were able to keep the bifurcation patent. Unfortunately, she died from hypoxic brain damage. This was a case, I think in retrospect, the patient was very lucky because the neurosurgeon on call was an unexperienced beginner, and he said that this aneurysm is beyond my horizon, do something. And despite this huge hemorrhage, we went ahead with this Piconis. This is the stent at this level, at the neck level of the aneurysm. We put the stent here, gave aspirin and Basilar, and coiled the aneurysm. On the next morning, the bus came and evacuated the hematoma, and the patient had a perfect recovery without the need to clip this aneurysm. The attempt to clip this aneurysm most likely would have ended similar to the case before, with obliteration of most of the MC branches. This is a huge basilar bifurcation aneurysm, again treated with a Piconis stent, and I want to show that to leave this remnant of the aneurysm in the acute phase is just right. So it makes absolutely no sense to try to, in this acute phase, to reconstruct the bifurcation of the basilar artery. It simply increases the risk. It has no benefit for the patient. This can be done later. In case the patient survives, we would rather do this, let's say, 6 weeks or 2 months later. And the risk of re-rupture from this remnant of the aneurysm close to the basilar bifurcation is very little, if not inexistent. Another concept of treatment, this was a ruptured parophthalmic aneurysm. This is the aneurysm severe hemorrhage Henkes 4. The parophthalmic aneurysm has not a really wide neck, but it's unfortunate anatomy. So we coiled the aneurysm, leaving the neck remnant, and once the patient recovered, we came back, put a flow diverter underneath the aneurysm neck, and this is June 2017, and the follow-up in January 2019. You see the parophthalmic part of the segment of the internal carotid artery is beautifully reconstructed. The aneurysm is completely isolated from the blood circulation with a very good clinical outcome. So it makes a lot of sense to go for partial treatment in the acute phase and to go for perfection in case the patient was able to survive for the following, 6-8 weeks. This was a very, very interesting patient, a young man. He came as polytrauma to us. His only polytrauma was the fact that he was working in the office as a public relation manager, and he was falling off his chair. So this was his polytrauma. He had no trauma, actually. He had, at the very same moment, a subarachnoid hemorrhage and a retroperitoneal hemorrhage due to the rupture of a lineal artery aneurysm. The underlying vessel disorder was segmental arterial mediolysis, which caused, so this was clearly a serious problem, but he was about to die from the ruptured intra-abdominal aneurysm. He underwent splenectomy. We did an angiogram, and the only thing we saw which was not normal was this little bleb on the basilar artery. This was on April 2016, 25th of April 2016. He was surprisingly recovering from both conditions until the moment on the 10th of May, so this is 15 days later, 10th of May, he re-ruptured. And the angiogram now showed that the dissection of the basilar artery now has developed to a huge dissecting aneurysm of the basilar trunk. And I mean, as you can imagine, this is a real challenge. So what we did is we went for partial coiling of the aneurysm very carefully, knowing that these kind of pseudoaneurysms are extremely fragile. You just touch the wall and they go down. So we partially coiled, loosely coiled the aneurysm, gave aspirin and Basilar to the patient, and implanted a flow diverter. This is 1 year follow-up. The patient fully recovered. The only real complication was the sister of the patient. She studied medicine in Heidelberg, and she explained us that this is kind of an experimental treatment which should not be done. So the large angina aneurysms are fortunately rare. The rupture risk is very high, and those aneurysms should not be observed. They should be treated right away. It makes no sense to go for any kind of conservative management. Most of those can be treated by endovascular means. As you have seen, sometimes some sort of creativity is necessary to get rid of these aneurysms. Parent vessel occlusion still remains a good choice for giant aneurysms, especially for parophthalmic and PCOM aneurysms if the patient has a complete circle of Willis. Flow diversion or a combination of flow diversion and coil occlusion is a very good choice, and it's an appealing option, especially for large and giant sidewall aneurysms. Thank you very much.
Thank you. Thank you so much, Professor Henkes, for sharing your experience. Is there any questions from the audience?
Otherwise, I'd have a question. We know that when patients have stress, like in subarachnoid hemorrhage, that then the platelets recover faster. Have you seen that? Do you see that? Do you change, or how often do you check for anticoagulation? Do you use a different regime? Do you need higher doses?
Yeah, we. In the era of stent-assisted coiling and flow diversion, we use a lot of a lot of highly thrombogenic implants. As a matter of rule, a rule of thumb, I would say, while 100 milligram are enough for a patient in a regular condition, we start for patients with subarachnoid hemorrhage with 3 times 500 milligram per day. In the morning, midday and evening, 500 milligram IV. Then we start measuring this. We measure the response, and then we are tailoring the dosage. You see patients needing 2 or 3 grams of aspirin in the acute phase after subarachnoid hemorrhage. So forget about 100 milligram, it's nothing.
Mm-hmm. And one more question for me. You mentioned this in this case where the rupture MCA with intracranial hematoma. So the not so experienced neurosurgeon referred it to you, and you mentioned that the next day, under dual antiplatelet therapy, they evacuate the hematoma.
Sure.
Do you have a tough discussion to ask them to do the evacuation of the hematoma under dual antiplatelet therapy in our department?
For any reason, I cannot tell you why. For any reason, the combination of aspirin and Brilinq for surgery is terrible. These patients are bleeding like hell. And for any other reason, the combination of prasugrel and aspirin is much better.
Not only prasugrel plus aspirin.
Yeah, and this was an uncoded, a year-old case.
Yeah.
This was aspirin and prasugrel prior surgery. No serious hemorrhage.
And my question, if I have to do it in my department, I will have just no answer to me from my neurosurgeons if I ask them to evacuate hematoma under aspirin.
So this was done by the boss. He previously had a colleague from Russia. He did everything for me for 1 bottle. So every aneurysm was 1 bottle of vodka. So you should find any deal with these guys to help you.
I understand. It's interesting. Thank you once again. Thank you very much.